Welcome to the Knowledge Well. I'm FullWell founder and CEO Ayla Barmmer, and today we're in conversation with Director of Research and owner of OmegaQuant Analytics, Dr. Kristina Harris-Jackson. Dr. Jackson is also a registered dietitian, and she's the assistant professor in the Department of Internal Medicine at the University of South Dakota, Sanford School of Medicine. She also holds a Ph.D. in Nutritional Sciences from Penn State. Kristina's research is specific to omega-3s and maternal health. In fact, she helped create the prenatal DHA test and the mother's milk DHA test, which are two lab tests that have proven to be extremely valuable to all of us practitioners working in the fertility space. So I am thrilled to introduce Dr. Kristina Harris-Jackson.
Okay. Hi, Kristina. Thank you so much for joining me here today to talk a little bit about omega-3 fatty acid status, testing, assessing in our clients and patients, what the current kind of intake level looks like and some of the areas that could use improvement, particularly in the stage of life of the perinatal stage of life. So really fertility through postpartum is what we're most interested here at FullWell and FullWell ambassadors. I'd like to just introduce you, give everyone a little bit of a background on you and your experience. So Kristina Harris-Jackson, she is a Ph.D. RD, and she is the director of research and a part owner of OmegaQuant Analytics. She's also an assistant professor in the Department of Internal Medicine at the University of South Dakota, Sanford School of Medicine. Kristina received her Ph.D. in Nutritional Sciences from Penn State in 2013 and completed her training to become an RD, Registered Dietitian, in 2014. And Kristina continues her research in the area of omega-3, specifically omega-3s in maternal health, helping create the prenatal DHA test, which we're going to talk a little bit about today, and the mother's milk DHA test, and continues her clinical work by consulting with clients on their lab values from OmegaQuant. So again, welcome.
Thank you.
Yeah,
Great to be here.
Yeah, really excited to have your expertise here. So with FullWell, we obviously just launched our fish oil product, which we're really excited about because we really felt like that was we've got this really comprehensive prenatal multivitamin that covers the vitamin and mineral needs, but we know you've got to have the essential fatty acids on board too. So let's just start there because one of the things that we really try to do at FullWell is empower consumers, empower our ambassadors to working with their practice clients to have the knowledge to make really informed decisions. And one of our values at FullWell is that empowering knowledge, but it's also, cost effectiveness, accessibility, not creating a line that's so out of reach for consumers that it's really difficult. And still, as an RD like you are, focusing on food first. It's in supplementing when and where we really need to, right? And that's how supplements really should be. So can we just talk a little bit about, the potential need for omega-3 fatty acid supplements, or I should say just essential fatty acid supplements, what the average person, is getting in?
What is average? What does that even mean? So what I've focused on a little bit more is looking at pregnant populations and I prefer it when I can find NHANES data, when you can find data that's from representative data sets. Because when I look at the people who were tested with OmegaQuant, that's not a representative sample of the US. That's like a very health conscious focused type of population most of the time. So they typically have higher average levels than what we see in larger studies. So NHANES data is always kind of delayed because it takes a while to collect the data and then publish the papers, but some of the data I've seen from NHANES, which is a US representative sample of pregnant women or women of childbearing age, is that DHA intake specifically is about 60 milligrams a day. And the recommendation for pregnancy at the very lowest level is 200 milligrams of DHA. And that's like a very low level. It's actually technically 300. There's an assumption that women get 100 milligrams a day and then add on 200 milligrams for a total of 300. That's kind of the original recommendations. But we are seeing the average is 60, the average. And the part of the big problem is it is almost the natural sources of DHA is just fish and seafood. It's really not like other nutrients where it's all over. I mean, it can be in more than one specific food group. And fish in pregnancy has been particularly tricky because fish there was the mercury recommendation by the FDA that pregnant women should avoid fish because they didn't know. Research, there's been a lot of pushback from the nutrition community saying not having fish is actually a worse outcome than having fish in pregnancy, because they are a source not only of omega-3s and one of the only food sources of omega-3s, but also so many other nutrients, including choline, which is also shown to be pretty important when you're kind of incorporating DHA into your cells. And so that's a very long answer because I'm a researcher and I never give straight answers. But at the end of the day, pregnant women in particular have very low intakes, and some of that is that fish fear. And so I also think in pregnancy, food is a little tricky. You're not really wanting to eat everything. And so I like the option of a supplement because then it just kind of takes the stress off the table, hopefully. There is a lot of stress around fish intake. And there's a big push to try and eliminate that. But in the meantime, you can have a supplement that is very low risk and meet the needs of a pretty specific nutrient that you're not going to get anywhere else, really.
Yeah. So you made some really good points there. I mean, right. Like the advantage with a supplement is, if there's a taste aversion or like an access issue or like, still a barrier to understanding like how to cook and prepare it. Those can all be barriers to intake in general, as well as just, pregnancy aversions. Right. And so supplement could really help with that. And then, if it's a quality supplement, they're doing independent, what we'll do is independent third-party testing for all of those contaminants of concern. And then we actually we do some additional contaminants beyond the heavy metals too. So that can help. And you pointed this out and I agree. I mean, really for essential fatty acids, the best sources are absolutely fish, seafood, right? Maybe we could talk for a minute about, I have down, what I've always used for numbers in terms of what the plant-based sources of essential fatty acids. So like chia seeds and flax seeds and things like that, that's actually ALA, really, right? And that needs to be converted. And from my research, and I'd like your take, that's it's a pretty inefficient process. And there's just a very small percentage that ultimately is converted. Could you talk about that a little bit?
Yeah, it's a great question because using the term essential fatty acids, that's much bigger than long chain omega-3s, marine based. So this is always wildly confusing, but they're in the same family. So omega-3s and omega-6s are essential fatty acids, and they're polyunsaturated fatty acids. It just means they're a type of fat. They're a special kind of fat. They have a lot of carbons on them, and they have a lot of double bonds, and that's where the name comes from. So it's just very nerdy. But when we think of polyunsaturated fats, it's fats that are liquid at room temperature. So oils, not solid at room temperature, like a butter, that's saturated fats. So the essential fatty acids, we're just going to look at the omega-3 side. It starts with alpha linolenic acid. That's what's in walnuts and chia seeds. And we have to get that. Our bodies can't put a double bond in the right place for that specific fatty acid to be formed. So it's essential for your body to function. And, but the body can take that ALA and convert it through a series of adding carbons and taking away hydrogen is making more double bonds to make longer, really specific structures of fatty acids that have specific functions in the body. And so it's cool because in pregnancy is probably the most efficient we can ever be at converting ALA to DHA. The estrogen increases the efficiency of that process, but it's not so much that it makes up for how much your body increases its levels when you take in preformed DHA or EPA. So EPA and DHA are kind of at the end of the chain of this process from ALA to longer chain fatty acids. And there's just a lot of enzymes in the middle that can kind of stop the process. And so EPA can be increased with high dose ALA, but DHA is really hard. So being pregnant is really the only times where you have an okay conversion. And women tend to have higher DHA levels than men across the board, but the magnitude of difference is just very small. So when you take a DHA supplement, and you say your average DHA level in your blood is like 4%, if you take a supplement, you can bump that level up to 8% fairly easily with a fairly high dose supplement. There's almost no way your body could do that. It would increase from 3% to or 4% to 5% maybe if you take a lot of ALA. So there's just a really big difference in how big that change is. And that's really important.
Yeah, absolutely. I mean, it really makes me think of, vegetarian and vegan, fertility and pregnant, postpartum, clients and practice, as I'm sure practitioners listening are probably thinking of that as well, because they're certainly at risk for a number of nutrient deficiencies. I mean, choline's another big one that you mentioned earlier. But yeah, those essential fatty acids, I think what I've seen is the perception or it being talked about like omega-3s they're all the same, right? And so, and they're not. Bioavailability is big here. So, okay. So that's really good. So let's get into, a little bit about the importance. So I have focused quite a bit with FullWell, and I'm really passionate about not just focusing on like the nutrition and nourishment during pregnancy and postpartum when we start thinking about like, really improving that or increasing it, but really pre-conception, working on like building your stores up, getting to a good place. So not only conception happens easily and the pregnancy is less complicated, but it makes everything run smoother, right? So I'm curious with your research, what you've seen at OmegaQuant, do you have a sense of, have you looked at like the preconception period much? And what's your take on that?
Yeah, that's a great question. And I think you're right on as far as having your stores up, having a good amount of not only omega-3s, but all kinds of nutrients built up before going into such an intense process as pregnancy helps avoid some things. And finding data on pre-conception is difficult. It's a difficult area to study because it's hard to recruit. You don't know who's going to get pregnant. So it's like you have tons of people. But I would say we have data. This is kind of the story of omega-3s in my mind in general, is they do the best work is when they're on board before there's an event, like an inflammatory event, an illness, a heart event, pregnancy. When they're already in your body, then they can come on, prevent something, or just improve the healing process. So in pregnancy, there's all kinds of stuff going on. Inflammation is involved. Everything is involved. And so I think that concept fits. The best data I have to kind of back that up is in the last few pregnancy studies using high dose DHA to prevent preterm birth. Both of these studies, one was in Australia with about 5,000 women, one was in the US with about 1,000. And they found, regardless of essentially which group they were in as far as getting placebo or omega-3, having a higher baseline omega-3 DHA level reduced risk for early preterm birth kind of across the board. So any woman coming in at a higher level just had a better chance of having a full-term pregnancy across the board. And so those people are entered into the study about between 12 and 20 weeks. So it's not preconception, but the earlier in pregnancy they had that higher level going in, very likely. And so we can kind of assume like that goes along with getting your levels up in preconception. And I would also say it probably takes a lower dose preconception to get the same effects as if you're coming in very low and then you kind of have to catch up.
Yeah.
And you have to take a higher dose, and that's more expensive, like, so I think that is actually very true, is you don't need to be on super high doses all the time. For a treatment, you might, but if for prevention, a smaller dose over time really does build up.
Yeah. And I mean, the advantage there is more cost effective in a lot of ways, right? Probably easier to take and tolerate, even though I've not personally found, most fish oil supplements to be difficult to tolerate, other than, if it's not great quality, or, depending on how it's formulated, there can be kind of like the burping, the aftertaste, that kind of thing, which we've not seen, with our fish oil. That was making me think of another. It kind of is like what you described. I think of building stores up versus starting after conception. I mean, first of all, there's so much that happens early pregnancy that, there's just the needs early on are really are intense, even though, we think of like third trimester as being more, but it's kind of like filling the bathtub with the drain open, right? If you're trying to just, once your needs have increased so significantly too.
That's really good. Yeah.
Okay. So now this gets me into some questions here about testing, when to test, when that makes sense. How do we, who's a good candidate, right, for something like the OmegaQuant test? And maybe we should really start with just you describing the testing options that you guys have. Who's a good candidate for it? How frequently you may do that, and how that would help you adjust, your protocols with your clients.
Absolutely. And we just got so much more information about this in the last few years for pregnancy because of those 2 big studies I talked about. But OmegaQuant is a lab that was actually started by my dad to test omega-3 fatty acid status as essentially a clinical marker, like you get cholesterol or blood sugar tested. So him and German cardiologist, Dr. von Schacke, created the omega-3 index as an omega-3. It was really actually as a risk factor for heart disease, but it also happens to be a dietary nutritional biomarker, and a very good one. And there are not a lot of really good ones. So this one is the omega-3 index, and all of the omega-3 status tests that we do are based in a red blood cell. And so it's very similar to HbA1c in that it's this long-term status marker. So it's kind of takes over the last 3 or 4 months of your diet, how much omega-3 you've been taking in, and it slowly changes over that period of time. The other side of that would be a plasma marker, and those levels go up and down every day. After you take your supplement and it's absorbed, your levels can be high, and then hours later it'll be low. So the red blood cell is really steady. So as far as who would be a great candidate to test, besides it would be great if everybody could get nutritional testing, of course, but women who are known to be vegans, vegetarians will not eat fish. So anyone who doesn't eat any fish at all would be a great candidate. Anyone who's not taking a supplement can be a great candidate. You could do a very short food frequency questionnaire about it's easy because it's just about seafood essentially. Right. So you can ask 2 questions and get a good idea. So you could do that at the beginning of pregnancy at some of the first sessions, a 12-week or the first trimester meeting. So you could test then, and then you could see where are we at on the spectrum. Do we need to give a higher dose, or is a kind of a normal dose okay? And I'll talk about what I mean by higher or normal doses in a minute. So you can do it to decide which course you want to go as far as dosage goes. You could also use questionnaires to start that process. So they're not taking any, you're going to give a higher dose. And then later on in the pregnancy, you can test as a compliance marker, or as are they absorbing it kind of marker. So I kind of like to see, if I had my way, someone testing at 12 weeks or before, like preconception, and then again at like 28 weeks or the beginning of the 3rd trimester, just to make sure that not everybody absorbs it, even if you're taking it. So
Yeah.
sometimes you just need something different. So the kind of clinical, what I like to think a good way to use the data would be is to use the omega-3 index is EPA and DHA, but we have a prenatal DHA that is just about DHA in pregnancy. EPA is not shown to be nearly as effective or predictive as DHA. So we focus on DHA, and then the level that we've seen in multiple research studies is about 5% of your red blood cells is DHA is a good place to be. It means it's not really that high, but it means that you're replete is what I like to call it. Not necessarily optimal, but replete. And what we've seen from these two studies, especially the one in the US, is that women who came into the study above 5%, it didn't matter if they got 200 milligrams a day or 1,000 milligrams of DHA a day. Both of them had low rates of early preterm birth. Women who came in below 5%, if they got 1,000 milligrams a day, their risk for early preterm birth was about half of the women who got 200 milligrams a day. So everybody got DHA in the study, but they found that if you started out low, below 5%, it really mattered if you were given 200, which is kind of the normal dose, versus 1,000. But if you're above 5%, you don't necessarily need 1,000. So it's that difference of higher, lower dose based on where you're coming in. It's makes a lot of sense. So if you test early, you can use the data for that. The third trimester test would be making sure that they're getting above 5%, because on 200 or 1,000 milligrams a day, you should be able to get above 5% unless you're really deficient. So coming in at 3%, you're going to need more than 200 to get up to 5. You're gonna need 500 or 1,000. 1,000 is not necessary for everybody. And so those are, there's lots of different ways to do it, because access, cost, what's the most effective way to use the testing really makes a huge difference. But I think testing at least once during pregnancy gives you an idea of, is this person absorbing it? Are they taking it? Is there something going on where they just can't keep it down? You know, there's so many things that can happen. So I like the testing, to me, helps relieve some of the maybe like the judgment on people if they don't want to eat fish and they're having a hard time with their supplements. Maybe we can find another way. Maybe we don't have to get you up to really high levels. You don't have to take tons, just getting enough.
Like giant gel caps and many of them, right? Because that could be the case with the 1,000+ milligram.
Oh, easily. And very expensive. It can really get expensive. And so I would love, my dream is for that the DHA testing would be within the standard of care. So to have that be extra, and then you could pretty easily know who to go at the high dose or or say, get, you know, a good prenatal 200 or 500 milligrams, take it the whole time. It's like 1 or 2 smaller pills. That's my dream. So we can just like have that nice cost benefit, just making sure women get what they need, but not scaring them. Scare anybody. It's just something that can help.
Right. So because it really kind of, the recommendations feel a little all over the map when you look globally at what's going on. Like, you know, you mentioned Australia and some of the research out of there. And I had seen recently that they were upping their recommendations to 800+ milligrams of DHA daily, right? Which would be a very expensive supplement, and may not be necessary, right? Especially if someone has got lower levels on board a little longer preconception, maybe they're testing and, you know, seeing that it's not necessary, right, to prevent the biggest risk. Would you agree with that?
So the 800 milligrams for Australia might be, they're trying to start a process of using the testing early on, and that might be their recommendation for women who are low. But there is something to just the recommendations keep getting ratcheted up a little bit, from 200 or 300 milligrams to 500 milligrams to 800. And some of that, I'm not sure that 200 or 300 milligrams wouldn't be enough for most people. That is equivalent to about 2 servings of fish a week. Someone's doing that consistently their whole life and through pregnancy, probably have pretty good source. You're probably at 5%.
Mm-hmm.
And I think that's probably okay. I would rather have most people at that level than some people really high and some really low. And what seems to be happening is that the rich are getting richer and the poor are getting poorer. Like the
Yeah.
people who are lower are continuing to not get anything. And then people who already have decent levels are learning about it. And then they're getting even higher, maybe not getting, and that's not helping the benefit across society.
Yeah.
So where we've seen almost all the effect for preterm birth is in women who start out low. It's not in women who come in with decent levels. It's just they're already replete. So adding on dosage isn't going to show an effect in a scientific study. So what I would say as far as like the ranges and the doses going all over the place, part of it is that blood level issue of we don't know where they're starting. Part of it is assuming women are taking their supplements is also a big assumption, huge assumption. So it might be that if everybody actually got to 200 or 300 milligrams a day, there would be a benefit, but we don't, no one's, they're at 60 milligrams a day. People aren't doing the current recommendations. So we keep upping the recommendation number without being like, well, why are we having an issue with even just getting to the bare bones of it? And part of it is that treatment effect versus a prevention effect. Yeah. If you need higher and higher levels to treat, because women are coming in with lower and lower levels, it's going to up that recommendation level, but we don't, that's not necessarily, I think, what the biology makes sense of. So yeah. Lots of that makes so much sense. That's really fascinating. I struggled, and I reached out to you a few years ago, actually, at this point too, but I struggled a bit with trying to decide on the level based on just the variability and the recommendations and the research and, you know, and really like where to go. I'm curious your thoughts, you know, your honest take a bit on our formula. We've got it's going to range. We're shooting for right now, this current lot has 430 milligrams of DHA. We're probably going to land on average close to about 400 or just above. And then with the EPA, it's at 120, between 120 and 200 milligrams per serving is about what we're going to be at. I like that. I like having both EPA and DHA. Yeah. Even though EPA doesn't have as many obvious connections to blood levels, they're both come together in nature. I always think it's a good thing for them both to be together, and they both work synergistically, it seems like. So getting 500 milligrams of EPA and DHA a day is great. I have no problem with that dose. If someone needed to have that 1,000 milligram dose above 800, you can just just double it. But for anyone, that would be a wonderful dose for pregnancy, be a great dose postpartum. We did a study in postpartum looking at blood levels and intake, and the lactation period is a higher need time than pregnancy for DHA levels. We saw that when women were taking just 200, it was a controlled feeding study. Their red blood cell DHA levels didn't move in lactation, where if you're given 200 in pregnancy, the red blood cell levels increase, but everything went into the milk. So we saw DHA in the milk go up, but red blood cell in the mom not. So to me, that's like, it's all going into milk. They need more probably than the pregnant woman does, but I think a 500 milligram across the board is good for women who don't have extremely low levels. Yeah. So 500 milligrams kind of combined, right? Combined. Yeah. I mean, postpartum too, I'd love to talk about the testing options there and where you see, is there a benefit to testing breast milk or not? Obviously, I mean, I've been postpartum before. It's not an easy time to do anything extra, especially if you're breastfeeding, right? But I am curious about it. You know, we know that what mom consumes, both from diet and supplements, absolutely directly influences the milk, including fat intake from any source, right? And, you know, certainly the omega-3s, essential fatty acids. So what value can we get again from, I mean, I can guess kind of the value there, but from testing the breast milk, and when might you do that? Yes. So we can test breast milk, or mother's milk test is to test DHA levels specifically, again, in breast milk. Our target is 0.3% essentially. It's again, a little bit on the lower end. Other people are looking at getting at 1% DHA, which is great, but where the best bang for your buck is at least getting above 0.3%. That's again, somewhat related to like a 2 or 3 fish servings a week kind of pattern. So I really like that. Testing your breast milk levels will go up and down much more quickly than your red blood cell levels. And so if you are curious about like, am I doing enough? Do I need to get more? Am I just getting sucked dry? Testing breast milk levels, they can change within a month or within a couple weeks. But so we recommend testing once you have mature milk, because there's a lot of stuff that's going on before that. And then if you find you're low, increasing your intake, either supplement or fish, and then testing again to make sure, like, do I need to take this much? Can I back it off? You can really tailor it a little bit more because it changes more quickly than the blood. The other thing is, if you have higher levels in pregnancy, if you've taken more supplement or eaten more fish, you tend to have a little bit more of a buffer, higher DHA in your breast milk for about the first 6 weeks. After that, it's completely based on your current diet. It doesn't matter what happened before that, but you do have a little bit more of a buffer than if you didn't. And we also see that most women have a pretty big decrease in DHA blood levels right after birth.
Makes sense. And it makes sense, but do you have some ideas on the mechanism there?
I think it's a depletion.
I'm
not sure in every way, because not only to heal the body, but also it's going out in the milk. And DHA and arachidonic acid, which is an omega-6 that's essential, that your body has a better storage of usually. Both of those are preferentially pulled into the placenta. Over every other fatty acid. The placenta is pulling that in from pregnancy, and then they're also, I believe, preferentially pulled in from milk, because they're not really used for energy. They're used for really specific purposes, almost like proteins, I feel like. And so it's really, the body will take from mom to give to baby. For when it comes to DHA, it will deplete mom's stores.
So one last question I have for you, and I'm not sure if you've seen this, but I know I've seen a lot of it. I've been asked by clients about it. I know a lot of colleagues that have been asked. There's kind of a growing camp of practitioners that are in, I think they're described as like a pro-metabolic kind of crowd or community. And there's this idea or thought process that any polyunsaturated fatty acids are problematic. And I believe that, the concern is the depletion of vitamin E, but they're quite anti omega-3s. Have you given some thought to that, or any thoughts, I guess?
I mean, I guess I usually am hearing about like anti omega-6, omega-3, and that's usually where we're at, but just all polys in general. I mean, there is an essential feature of polyunsaturated fatty acids. I think maybe dosing, maybe they're like, oh, we're giving way too much of these omega-3s. There could be something to that, because with our new types of supplements, we can concentrate omega-3s more than we ever could. So we are getting away from more natural dosing. And so I could listen to that argument. I don't like to say any nutrient or food is ever toxic or poison or anything like that. And I think polyunsaturated fatty acids are necessary for the body to work well. We've shown that, but there's lots that we don't know. There's a lot of nuance, and we're still sorting it out. When it comes to omega-3s, there's been a lot of research, probably too much research, so that we are completely confused now. But there's a lot of safety data. In pregnancy, it's very safe up to pretty high doses, which is kind of a different question. But when it comes to omega-3s and pregnancy, just to quickly say it, really high doses have been related to having too long of a gestation. So going past 40 weeks. There's not a lot of evidence that it actually statistically pushes people out to 42 weeks, but you might be at 41 plus 5, like, it does what it's supposed to do, which is, it seems like it elongates gestation. which is why it reduces preterm birth, but it can go too far. So
that may have been me.
Yeah,
I had pretty long pregnancies. Yeah.
But it all worked out just fine.
Yes.
And so there's that option. And if that's something that's a concern, you also can stop taking them around the time you're ready to be like, we need to be done. We need to start processing. Because there are some studies that show like the effect of it can be pretty fast, where once you stop taking it, there can be birth coming quickly after that. But so that, and then there's also, people are always concerned about bleeding, and there hasn't been shown to be excessive bleeding loss when you have a high omega-3s. There's sometimes more blood loss technically, but it doesn't actually hit the point of being a severe bleeding event. And so that's another function of omega-3s, is it reduces your blood's, it elongates the clotting time. So it takes a little longer to clot, but it still clots. So it's not like warfarin, which completely eliminates it.
So is I'm glad you brought that up, because, you know, my thought, and I don't know, you know, I'd have to look and see where I really got this from, but, you know, my thought was that was a little more associated with high EPA, but is it across the board, just total omegas? Like there's no difference there?
That's a good question. I'm not sure I've ever really seen it broken down between I just seen high doses in general.
Just total. Yeah. Okay.
Yeah. But that always comes up as a concern, and it's, and pregnancy is a, you know, place where you could have some major blood loss. So those are, I think, the two main things that a higher dose omega-3, where you wouldn't want to be too high. When it comes to like the gestation going on for too long, you don't want to make that happen. But for the most part, as far as actual severe events, it doesn't actually reach that level. It just tends to push it longer. So
okay. And that number, what that high number would be, is dependent on the individual, or is it, do we see it at a certain number, like a couple of grams or more? I
don't know if I know that the Australia study, they actually stopped supplementation at 34 weeks because they were concerned about the long term going too long. Most studies go all the way out to delivery, and don't, there's not, that's a good question. I don't think the most recent studies are much higher dosage. They're 800 and 1,000. And before that, it was more like 600 milligrams.
Of DHA only, or total omegas?
DHA only that I'm thinking of. There are other studies there's a lot of these studies done in the Scandinavian countries where they do actually give a lot. There's some where they gave 2 to 6 grams of fish oil. Came out closer to like 1,000 DHA. Okay. And they didn't see any clinical issues as far as going too far past, like they look at all of the safety data. And almost all the time, omega-3s are associated with better outcomes, less than a few days, less preterm birth, you know, the big things that cause it. So on the whole, more omega-3s has been shown to be better up to a fairly high dose. They've tested, you know, at least a gram of DHA is quite a bit of just DHA.
Yeah, it is. Yes.
So,
and it makes it exceptionally expensive.
Yes. So that's not really an answer, but
no, you are packing so much in. I mean, you are a wealth of knowledge. You know, Kristina, thank you so much for this. I think I kept you longer than I said I was going to. So, I mean, this is fascinating. I wish I could just keep talking to you. But I'd love to just wrap up with, so I know OmegaQuant has very kindly offered FullWell ambassadors a nice discount to order the test, which I really think that people are going to want to try to use this with their practice clients and patients now after this talk that we've had. But this is a test that consumers can order directly as well. Is that right?
Yep. It's great. Available on our website. And then we also have partners that have it.
Fantastic. Thank you so much for your time. I just really appreciate it. And you taking the time to educate the community, and I'm really interested in, the testing options and sharing that also with the FullWell community. So we do plan to do that, but thank you so much.
Yes, thank you. This was very fun.